It's great to be back in Brazil and visit with many old friends and making new friendships and colleagues. And I too, like Rhonda Rogers, really enjoyed our noontime with the students yesterday. It was just a wonderful experience. And I think it's a great opportunity with all of the faculty here today to take advantage of talking to the various faculty from around the world and also seeing where you might find new opportunities for research, collaborations, places to do postdocs, your thesis work, or just simply setting up new collaborations. What I'm going to talk about today and focus on a topic that was brought up, but focus a little bit more on some of the newer area of the immune system. I'm going to focus on the monocyte-macrophage from the immune system perspective and link to cardiovascular disease. I'll just have to figure out how. What we know here is in population studies that there's a clear documented increased mortality due to cardiovascular in the HIV population. This just shows you some of the data looking at CVD as an underlying cause in heart disease. Deaths due to CVD continue to increase as a proportion of deaths among HIV infected. This is from a New York City registry group. But there's a lot of opportunities and many different cohorts of now studying cardiovascular disease and linking some of the underlying mechanisms. So I think this area and thinking about comorbidities, which Lish introduced yesterday to you, was this idea now that our HIV populations are aging. That's an important part for the folks here, the students to understand. Our patients are getting older. They're over 50, and I'm sure many of the patients here in Brazil are also getting older with their HIV disease, and it gives you a great opportunity to understand why are they developing these comorbidities, and how can you now evaluate them further in terms of some of the underlying mechanisms due to cardiovascular disease. We've had the abilities in the US to study a number of major cohorts that have been established for almost 30 years. That's both the WISE cohort and the MAX cohort. The WISE, you heard Danny Dewick introduce yesterday a bit. That's the women's interagency HIV study, and the MAX cohort is the multi-center AIDS cohort study. And we've now shown an association very clearly. This was just published recently in Clinical Infectious Disease, that there is progression in these cohorts of subclinical carotid atherosclerosis. And again, this is by measuring focal intimal media thickening, or IMT, and association is observed with relative risk increases in both men and women. So this is something that's affecting both populations. And then finally, it is persistently found in our suppressed HIV population, which I think it makes an important point, again, for the folks here in the audience to consider as we're thinking about these diseases and we're treating all of our patients, that we need to also now consider a number of these comorbid conditions. What we've been able to do and really focus on in our studies is to understand more about the role of the innate immune system in HIV, and this is something that's come up more recently from a number of studies that were published a couple of years ago. A study that I participated on with Alan Tenorio, Michael Letterman, Peter Hunt from the ACTG 329 study, where we showed that it was important soluble markers of the innate immune system, mainly related to monocyte-macrophage activation, but not T-cell activation. And so there was really a paradigm shift that the folks here should understand, that in the early pre-heart or pre-therapy era, folks like Janice Georgi, who did this work in the MAX cohort in the early 90s, found that it was really CD8 T-cell activation that drove pathogenesis, and CD8 T-cell activation was a better predictor for outcome than was viral load in some of those early studies related in the untreated cohorts. As we now fast forward almost 25 years later, we're now in the era of heart and viral suppression, and now we're thinking about a different target in terms of the pathogenesis of these comorbidities. That's related to the innate immune system, especially monocyte macrophages. And it's really these innate immune activations that are central to HIV and perturbations, and they may, again, persist with HIV control, which we've shown. Again, the activity of the cellular mediators promote atherosclerosis, and we're looking at pathways of coagulation, inflammation, lipid scavenging, cytokine secretion, vascular remodeling. And a number of folks in this audience have really contributed much of the work to this field, and I think it's an important one for study. What we found in an earlier paper here published in 2014 was that serum markers of monocyte and macrophage activation, soluble 14, soluble 163, and galectin-3 binding protein were associated with the presence of carotid artery lesions in the WISE cohort. And we actually found, by putting the three of these markers together as an index of cardiovascular disease outcome, we could find a more powerful statistical analysis for the outcomes related to these clinical carotid artery lesions. So we think we have, again, valuable biomarkers. We've then gone on to a combined study, and this is, again, a very large study. We looked within the whole of 1,313 WISE and MAX participants. And in this case, this was a vascular sub-study with B-mode carotid artery ultrasound imaging, again, between 2004 and 2013. So we had a full 9 years. Median follow-up in the sub-study was 7 years. So this is one of the first large and longitudinal studies to be able to look at the changes in biomarkers related to both in the women here, and this just gives you the dates when we performed the carotid artery ultrasound and the numbers of patients analyzed at each of these time points, both in the WISE, which is a women's study, and the MAX, which is a men's study. Now, these are different cohorts, and this is just showing you the outcome of interest if you're not familiar. Not being a cardiologist, being an immunologist, this isn't something I've ever done, and I think many of you in the infectious disease or HIV world as well, but this is a fairly easy technique that's been done and can be done in all of our clinical settings and research settings. It does show an increase in measured focal plaques and then measures of 6 sites near the far walls of the common carotid, the carotid bifurcation, and the right internal carotid. And then what we're looking at here is an outcome of an increase in number of plaques between the first and the last visit here over this 7-year period. So again, we have a nice longitudinal evaluation for intermedial thickening. This I won't go through in detail. As with many others here who've talked about statistics, we hire good statisticians to work with us on these studies. And that's another thing I'd really recommend as students, fellows, and trainees, is to really find a good statistician at your university. They're worth their weight in gold, both from this kind of analytic work and then in the systems biology field, which I'll talk a bit more at the end. I think those are people who are doing systems biology analysis, and Danny certainly introduced the topic with some very important folks that he's worked with that allows us to then analyze the data. This just shows you the clinical characteristics in 2004. And again, the beauty of both of these cohorts is that we have large numbers and match HIV positive and HIV negative subjects in both the WISE and the MAX cohort. Now, there are clearly some differences in the cohort as we look around in terms of the median age. The women are slightly younger, the men are older. We also note that there's differences in their race, ethnicity. WISE is predominantly an African-American cohort because that's where the epidemic is in the U.S., so we focus on the African-American Hispanics, and this is a population that was established of predominantly gay white men back in the early 80s. This was actually the MAX cohort, again, from an historical perspective, was I think, the first cohort probably in the world that was established to study HIV in the very beginning of the epidemic in the early 80s. So, and the reason why one could move into these cohorts, at least in Chicago, there was a large interest in hepatitis vaccines back then, and so they already had a large cohort of men, gay men in the north sides of Chicago, which they could then work together, and this was for those of you who might know John Fair and David Ostro, who started this cohort in Chicago in 1983. So it's been around quite a while across the country. Again, looking at smoking, some differences, BMI. These are African-American women, BMI is higher, and then also looking at the use of lipid-lowering agents is much less in the WISE and then on the men. So when we start to then look at the results of the serum biomarkers levels by the plaque formation and HIV status, what we find again are some significant differences across the cohorts. Again, this is looking at development in the women of 12% with plaques, And you can see the numbers here. I'm not going to go through them. 66 and 692 versus 26 with plaques, 112 and 391. The biomarkers we've looked at here are soluble CD14, soluble 163, galectin-3 binding protein, galectin-3, high sensitivity CRP and IL-6. And I might add that we did run a total of 313 samples, only excluded 32. And all these were run, I didn't point out on the previous slide, on a single lab of Russ Tracy's lab at the University of Vermont. So there is good quality control of having all the samples run on these longitudinal evaluations in one laboratory. And what we did find, as I can point out here, that soluble 14 was significant, had a high significant p-value both in the Ys and the max. Soluble 163 was not significant here in the Ys cohort, was in the max. And then as you look down, there are a variety, things like CRP, which is a major marker for cardiovascular disease in the non-HIV cohorts, hasn't really proven very effective in HIV cohorts. And a lot of it's probably related to the fact that HIV affects the liver, which is the main organ where CRP is synthesized. So we do find those differences don't exist. And then we did not see a real significant difference in IL-6. So what did come out is soluble 14 was probably the best marker in this group. When we look at the summary of the association of these inflammatory markers with plaques in terms of the combined cohorts and outcomes, the only significance here, and this is again controlling for all of the variabilities down here, I won't go in, but education, income, age, history of injection drug use, crack cocaine, body mass, blood pressure, total, and HDL, diabetes, EGFR. So we were able to control for all the variables that have the ability to contribute. And what we found in the end, the main marker that still came out highly significant was that of soluble CD14 that was associated overall with relative risk increases for cardiovascular disease in these. So what we found in this first study, and this study was actually just published a month ago in Journal of Infectious Disease, is that macrophage inflammatory marker soluble 14 is associated with new focal carotid plaque formation after 7 years in both infected and uninfected men and women. Soluble may play a greater role in virally suppressed men or women. I didn't go through all that with concurrent HIV and HCV, and we are now looking more at the role of HCV co-infection. We actually think that that may be another important driver in the cardiovascular risk when we see that, and soluble 63 seems to be a more important marker when you have both HIV and HCV co-infection. What we really need to do is more work to understand the reduction of these inflammatory markers to prevent atherosclerosis, and certainly we are trying to target this in a number of studies. And as we look at older patients, as you'll be seeing in your populations as we are as well, we need to actually think about these individuals more about the risk of cardiovascular disease. We've moved these studies forward now to understand more at the cellular level, immune activation, inflammation, and linking these more with metabolic changes. One of the newest fields in the whole field of immunology in general is that of immuno-metabolism. And I think it's an important area. At the recent International Immunology meeting in Australia, there was a lot of interest in immuno-metabolism across many fields. And I think this is a great area, again, if you're thinking about how it relates to HIV, but it relates to cancer, it relates to autoimmune, transplant. It's a field that's getting a lot of interest, and especially in cancer treatment. And from the immunology perspective, immunometabolism is an area of interest of how one can combine blockers of the metabolic process along with checkpoint inhibitors. And there are even now, I just saw this week, a number of RFAs out from the National Cancer Institute and the NIH for supporting that kind of research. When we start to think about metabolic consequences, we can look at the associations here of the steady state of the CD4 T cell, which is in metabolic quiescence, which you'll have low expression of a flow marker. So this is our newest interest in flow markers, GLUT1, which is a marker of glucose uptake. So you have low GLUT1, low glucose uptake, low glycolysis, minimal biosynthesis. So you have mostly an oxidative phosphorylative state. As you activate the T cells, they go up to an activated state here and become eventually metabolically exhausted with high GLUT1, they also begin to express more PD-1 as an exhaustion marker along with GLUT1, and then an annexin leading it to some of the death. And you can see then the drivers or the metabolic activation of other glycolytic pathways. What we've been able to do now is to look under a number of T-cell and monocyte populations, and these are just, again, general populations that we've studied both in Chicago and done collaboratively with our colleagues at the university, at the Burnet Institute and Monash University in Melbourne. And just showing you here that looking at what happens on HIV patients who are viremic and then on heart, looking at their CD4 GLUT1 expression. And what we find is that it's upregulated on HIV infection and not decreased significantly on therapy. So again, this is a marker, like many other activation markers, that stays up on therapy. When we then look at the actual distribution across subsets, we look at either the central memory, the effector memories, naives or terminally differentiated cells, and find that it's really this terminally differentiated population that has the highest levels. We've also looked and correlated this GLUT1 and CD4 cells in both viremic and suppressed, and find a high degree of correlation of percent, in this case CD4s, and GLUT1 expression that exists. So there is, again, a correlation with immune deficiency and GLUT1 expression. It's also found and increased on what we're now seeing as senescent T cells. So as we're looking at the questions of immune aging or inflammaging, and as you know, we're driving cells in the HIV patients to a more senescent phenotype. Those are going to be defined as being CD57 positive, CD28 negative, and those are known to be senescent T cells. Interestingly enough, we find that those are the cells that now have increased GLUT1 expression, and they're also, we find that those same cells, the PD-1 cells, are also GLUT1, and we've done the multiple parameter evaluation that these are the same populations of cells now. And I know maybe Dr. Letterman will have the question for me later on, because this is also associated with a CMV infection in our patients, and we are just now going back to see, does this also associate with CMV driving this phenotype, which we haven't yet looked at. We're also very interested in, as this talk is about monocyte-macrophages, is looking at glucose metabolism in monocytes. And again, GLUT1's a major glucose transporter. Activated monocytes increase GLUT1 expression, glucose uptake, and switch from an oxidative phosphorylation to a glycolytic metabolism. Same as the T cells, so we can now find that GLUT1 and increased glucose uptake can be measured in our monocytes directly. And we've then, this is the study design and methods that we've used. HIV negative, HIV positive patients, this is the viral load, who are viremic, and then HIV positive patients on therapy. We've done fresh blood, measured the CD14-16 subsets with GLUT1, HLA-DR, and then we can use another flow cytometric approach of 2-NBDG. This is a marker that you can measure by flow cytometry to do a functional assessment of glucose uptake in the patient. So in this case, we're looking at the total CD14 positive monocytes and looking then at the GLUT1 expression, percent expression, which goes up. These are the same patients that I showed you in the previous T cells. They're from the same individuals. They're HIV positive, viremic, and HIV on CART. And again, there is a significant difference between the HIV negative controls. So like the T cells, the monocytes maintain this glycolytic and more exhausted phenotype. This is just showing you that they produce higher levels of TNF as well. So the GLUT1 monocytes have a functional role, and this is looking at them here in terms of in vitro stimulation with LPS and interferon gamma, in terms of GLUT1 and then TNF expression. We've also gone on to look at the subsets defined by CD14 and CD16. As you know, CD14 is, we're beginning to think more about monocyte subsets from the innate immune system. We're not just looking at the CD14 cells. We can now define at least three major subsets of interest, and they've had a lot of interest in the cardiovascular disease world. I can refer you, I'm not going to mention any of the work today from Nick Funderburg and Mike Letterman's lab, who've done a lot of really elegant work on these subsets, initially linking them to cardiovascular disease. I think this is, if you're going to start to think more about monocytes, this is the way to approach it, is to look at these subsets directly. This is just showing you how we gate them by flow cytometry, the classical, the intermediates, which then express 16, and the non-classicals, which are CD16 positive, CD14 negative. And then what we can find is, looking at those three subsets, both in the HIV positive, viremics, and on CART, we again find elevated expression of the populations with GLUT1 across all three subsets here. So you have, again, the non-classical, the intermediate, and the classicals. And interestingly, it's the non-classicals, it's those CD16 cells that are most associated with inflammation that are the highest levels of this glycolytic pathway. So again, it links well to the fact that this may be another valuable marker as we're thinking about new markers in cardiovascular disease risk and potential. This is a flow marker that we're beginning to look at more. We also show that the intermediate monocytes, particularly from the HIV positive persons, have higher levels of NBDG uptake. So here we're looking at, here in the intermediates, both the viremics and those on CART, it is those that are the most functionally active in terms of their glycolytic pathway. Although they're not the highest level of GLUT1, they have the most highest activity for glucose uptake. So again, that's a subset we're focused on. We also find, at least here, the activation marker DR is increased in terms of using MFI analysis as well. And then in vitro stimulation of the monocyte subpopulations can also be shown to have increased glucose metabolism using a combination of lipopolysaccharide and interferon gamma, which are major activity markers. And I think you've heard, again, from some of the other speakers, Rick Kalp and others, about some of the important biomarkers that they've studied, like IP10, and I began to think more. We haven't really measured IP10 or CXCL10 in these monocytes because, as you heard from Rick's discussion, interferon and the LPS are important inducers of those molecules in some of the systems that he studied. And I think one could start to link now what happens in terms of the immunometabolism and the other aspects of the functional immune inflammatory pathways. So what we've now shown is that HIV infection induces a hypermetabolic state in monocytes. We think, yes, it does. The GLUT1 monocytes are there, and they show higher levels of glucose uptake by functional levels. It's not normalized on heart, but the intermediate monocyte shows the highest level of activation and glucose uptake. So we then took this one step further in our WISE cohort to ask, is based on intimal media thickening. So the assay I showed you earlier, where we looked at the number of the lesions using IMT, we then went back and correlated these changes in monocytes with now those patients with high IMT and low IMT within the WISE cohort, and this just gives you a lot of the different data. I'm not going to go through the details. We actually published this last year in AIDS, so I can refer you to a paper, Tiffany Butterfield, who I'll refer to at an end, a graduate student from the University of the West Indies. It's great to have collaborators in Brazil. It's also great to have collaborators in the Caribbean, because these are great places to visit for us from the far north cold in the winter time. So it's also wonderful to come here to visit in a time when we're having snow and minus 80 degrees. But what we did see in this study is, looking at the differences, we did not, interestingly enough, see differences between those with high and low IMT with regard to both the percent or MFI of GLUT1 on the CD4 or the CD8 T cell populations. But what we did end up seeing in comparing was that the GLUT1 expression on monocytes from the intermediate those with the intermediate phenotype did show a higher GLUT1 percent and MFI expression. So this is now similar to what I showed you earlier, that it looks like that GLUT1 population, the intermediate monocyte, might be the most important. Did I lose? I think I lost. Okay, I'm back again. Thanks, Tom. Anyways, what we've really shown here is that linkage is a functional outcome measure with regard to what we've seen in the previous slides of GLUT1, now associating it with cardiovascular disease outcomes. We haven't correlated in the larger WISE cohort and MAX, which we would hope to do soon,
is to now link these functional changes in monocytes with now the longitudinal data where we have the soluble biomarkers to now do this in a larger cohort with the cellular biomarkers. We've also shown activation markers, CD38, and again, it's elevated, on the intermediate and classical cells. So in summary for this part of the talk, GLUT1 expression on activated intermediate monocytes is associated with the development of the subclinical cardiovascular disease in women with HIV. We have plans to look at this further in the other cohorts, and GLUT1 may be a useful marker of CVD and potentially other inflammatory diseases associated with CART and treated HIV infection. I think this is a general phenomenon. This is the GLUT1 changes, as I said, this is not unique to HIV, but it is something that's being looked at very much in the cancer literature. And so when you look now, you can start to find this as a general phenomenon of immune activation and metabolic changes. So I think this is a great area for folks to start to think about how you can start to meld with other fields. And if you're looking at HIV cancer patients or other groups of patients with diabetes, which we're now studying, and other metabolic complications, this gives you a great inroads for understanding some of the mechanisms and eventually targeting. One of the areas that I want to point to is that this is all blood. And through many of the talks over this time period, over this last couple of days of the meeting, we talked about tissue. And I know I will quote my friend in the front row, tissue is the issue. I know he should have a T-shirts made for us, because he's the one, I think, who came up with that saying, and I think it's absolutely true. And this is really now thinking about metabolism in tissue macrophages, where we can promote and dampen inflammation responses. So again, I would point folks to think now about M1 and M2 macrophages, which M1s are more pro-inflammatory, more GLUT1, and make pro-inflammatory cytokines like IL-6 implicated in metabolic comorbidities, visceral adiposity, insulin resistance, type 2 diabetes, cardiometabolic diseases. So I think this is an area that we need to look at, is in that tissue, and finding then that the anti-inflammatory responses, these cells have been shown to have more oxidative phosphorylative outcomes. And where we're now beginning to look at this, and what we're doing and others in the field of HIV are now starting to focus on adipose tissue. So I think this is the new tissue of interest. We have folks who love the female genital tract and have been studying that. We've talked about the GI tract. We've talked about the brain. I'm going to get you into a new area. It's sort of like what Dustin Hoffman was told in The Graduate. You know, what they told him, remember what they said to him? Plastics, of course. Well, I'm going to say invest in the adipose tissue today, okay? This is where you should be putting some effort and thinking. And we're now working, because we get plenty of this from our surgeons who do obesity surgery, so we can get plenty of adipose tissue to start to do and work out the techniques and eventually start to do all this and biopsies. And we are working with collaborators to do this. And I think, again, tissue macrophage and metabolism are critical in adiposity pathogenesis. In obese, M1 use the glycolytic metabolism, which is central for pro-inflammatory profile. So I think now we're going to begin to start to look more at what goes on. And it's not, and there have been some nice work coming out from French colleagues, and also Dorothy Lewis's group in Texas has shown that adipose tissue, both in human and primate models, can serve as a reservoir for HIV and SIV. So I think, again, it's an important area to study, not only from the host immune system, but a place where both the immune and virus can interact. And although I'm not talking much about HIV here in my talk, I think that's a critical part of all these studies that we need to look at further. So the next area that we've been working on is to try to look more about cholesterol analysis in monocyte populations. And this is work we're doing in collaboration with Patty Mallon's group in University of College Dublin, and trying to understand is what happens in terms of cholesterol metabolism, and do we alter this metabolism and cholesterol efflux with HIV infection. And there's a variety of different HIV proteins, including NEF, that have been implicated in these pathways. In working with Patty, and this is some of the work that they've recently published, and we've submitted a grant on some of this work, is to now link a variety of gene expressions, especially ABCA1 and ABCG1, which are mediators of cholesterol efflux, and we're now beginning to look at whether or not these genes are altered and what happens in treated HIV infection you get decreased expression of genes regulating the cholesterol pathways. But we've now, with Patty, developing a number of different biomarkers at the message level, are looking at these variety of markers, LDL, CD36, PPAR gamma, SHREP, and LXRA, to now look at what happens both in the treated and untreated, and what showing, again, clearly that these pathways are regulated, and there's a decrease here you can see, although these are a little blurry, I think like some of the other folks in terms of the outcomes. There's also an assay that Patty's group has developed here, and this is now looking at the monocyte cholesterol efflux assay, quantifying this and standardizing it for total cell counts in HIV-negative subjects, so you can now begin to measure extracellular, intracellular cholesterol, and do this with ApoA1 and other measures of metabolic and lipid metabolism. And Patty's group has gone ahead and done this in the MCE assay in the MONIC study, monocyte intracellular cholesterol study. It's a cross-sectional study matched for age, gender, ethnicity, smoking, and Hep C status, 50 patients in each cohort. And again, showing here that monocyte cholesterol efflux in untreated is associated with enhanced, but not inhibited, which is interestingly enough. So when you're looking at the viremic patients here who are HIV positive, you get increased actual cholesterol efflux in these in vitro assays. And what then was shown further is that there's an increase in MCE may contribute to production of dysfunctional HDL when you get all this cholesterol, higher HRA correlate with higher cholesterol efflux at multiple time points. So this now provides, I think, an important additional functional measure with the monocytes, which we're now linking the phenotypic levels of their glycolytic pathways and their cholesterol metabolism. These are two different studies, but we're now together with Patty and collaborating on a grant submission is to try to link these pathways. And then one final area, I'll just go through this quickly, is, again, there's a lot of role for the cholesterol and monocyte and other pathways. I won't go into details, but I think this was just presented recently at the CROI meeting, that there's opportunities to now look at functional cholesterol pathways linked to a number of different markers here on our monocytes that we can now link to the metabolic pathways as well. And now we're trying to take this one step further to the systems biology, performing RNA-seq analysis on monocyte populations in HIV subjects with cardiovascular disease. This is in collaboration with Klaus Lay's lab at the La Jolla Institute of Immunology. Klaus is a cardiovascular immunologist who's been doing a lot of work in trying to develop the role of the immune system in cardiovascular disease in murine models, and now we've gotten him to work with us on the HIV. So this is just showing you how we've done this. We've actually done this on frozen cells from the WISE cohort. So it really says, and I'll show you the quality of the RNA data is really very good, that we can actually do this off a frozen monocyte population from the WISE cohort where we do staining. I won't go through all the data, sorting, RNA extraction, and then measuring and sequencing. This is just showing you the yield and viabilities from the populations, and again, sorting out here the CD14 classical monocytes, but we have the intermediate non-classicals as well. And we're doing this from 4 populations: HIV positive, CVD positive, positive and then negative, positive, negative, negative. So we're looking at all 4 different various populations now to begin to get gene analysis. And we've done this, and I'll show you at least some of the preliminary data, but it just says that we can now go from all the way from the huge epidemiology studies that we can go all the way down to a more systems biology and do this as a discovery phase, which is what we want to do, identifying genes. And I think for folks in the audience, you can think about this, working with epidemiologists, working with clinicians, and then working with systems biologists, really try to combine this in studies here in Brazil, where you have large numbers of patients. It gives you great opportunity to do science in many areas, not just HIV. We've now done a differential gene expression. I'm not going to go through a lot of the details, but we're now getting differences between, as you can see, the HIV, again, the 4 quadrants analysis of those that are positive and negative, and we find a variety of genes that are up or down regulated. This is just showing you the Venn diagram of the differences in the HIV positive, CVD positive, and the here HIV negative, CVD negative, which are the 2 extremes. We have a lot of differences between HIV and CVD, so they're clearly are more genes here that are different between HIV and CVD than there are between those that are both HIV and CVD. So there might be some unique pathways that we can find, and there are some overlapping pathways of upregulated, more upregulated than downregulated genes, as you can see. I'll just show you some of the early data on, these are the volcano plots, just to show you for gene analysis in the 4 quadrants. You can't, it's a little bit off the scale, but again, we're showing some differences here across both CVD and HIV that we're now exploring and identifying what genes are there. This is early days because we're just now analyzing the data, but the heat maps again show clear differences across HIV, CVD positive, HIV positive, CVD negative than the 2 HIV. So the most important, this group here looks to be much more different. There are a variety of genes that are there, and we're now just looking through. I don't have the gene names. We're now sorting through all the thousands of genes. This is all RNA-seq, but it just says that we've got data that we can look at, differences between those that are HIV positive and negative, and it may be that it's really HIV that's a main driver here. We hope to find some unique sequences of CVD within the HIV population ultimately, and this is just showing you the pathway analysis. And the pathway analysis shows what you might expect at the highest level. Inflammatory pathways are those that are driving these overall. So we have a lot of data. We're writing this up now for our first publication, but I think it shows you an approach, which is why I'm showing it with without a lot of the details of the data, of how we're now moving and combining all the way from large epi to now systems biology. So I'll now just conclude with my final slide, just to say that I think the monocyte is a key cell that we can study more of and understand its role in the biology of HIV and in cardiovascular disease, but not just in cardiovascular disease, which is what I've talked about today. We're also looking at this in diabetes. We're looking at this in neurocognitive outcomes. And this is clearly a cell that's relevant a lot to the metabolic pathways. One area I didn't talk a lot about, which we're combining with the studies with Patty Mallon and Bill Powderly at WashU, is to now do microbiome analysis and linking that in metabolomics to the macrophage outcomes and cholesterol metabolism, and those related to now immunometabolism. And ultimately, we hope that these integrated pathways will give us more insights in terms of the biology of HIV and give us insights in terms of a critical role for monocyte-macrophages and ultimately therapeutic targets for reducing the inflammatory pathways. I'll just thank my collaborators here on the first studies in Max and Wise, Robert Kaplan and David Hanna at Einstein. I mentioned Klaus Ley, La Jolla Institute of Immunology and Cardiovascular Biology, Patty Mallon on the cholesterol metabolism, and then University of the West Indies, Josh Anginger and Tiffany Butterfield for the immunometabolism. Thank you for your attention, and I'll be happy to take questions.